This is a video for research performed at Henry Ford Hospital by Dr. Daniel Ouellette and Dr. Jovica Valianovsky regarding the manuscript Risk Factors for Respiratory Hospitalizations in a Population of Patients with a Clinical Diagnosis of Chronic Obstructive Pulmonary Disease, COPD, published in the International Journal of COPD. COPD is a highly prevalent disease that affects greater than 24 million U.S. adults annually and has a substantial economic burden associated with it. Exacerbations account for more than 50% of medical costs and negatively impact the trajectory of disease. Traditionally, COPD has been diagnosed by demonstrating obstruction on spirometry. However, as an internal medicine resident, I noticed that many of my ambulatory patients with a diagnosis of COPD didn't have obstruction on spirometry, but clinically behaved identically to patients that did. I shared my observations with Dr. Ouellette, and he mentioned that recently there's been increased awareness that some patients with a history of smoking had signs and symptoms consistent with COPD without having demonstrated obstruction on spirometry. We discussed how challenging it is to care for such a heterogeneous population, especially as management of patients diagnosed with COPD without obstruction is not well defined, nor is there hospitalization rate or risk factors for respiratory hospitalizations. This discussion is what led to us pursuing this study. We chose to study a population of patients that were clinically diagnosed as having COPD at Henry Ford's internal medicine clinic. We only included patients who had spirometry performed and used Gold's classical FEV1 over FVC ratio of less than 70% to determine if obstruction was present or absent. We compared patients who had obstruction to those that did not in terms of demographics, comorbidities, spirometry, eosinophilia, respiratory treatment, and hospitalization for respiratory problems. We hypothesized that patients with obstruction would be more likely to have a respiratory hospitalization than those that did not have obstruction. We then examined these groups for risk factors associated with respiratory hospitalizations. During 2014, we had 657 patients clinically diagnosed as having COPD in Henry Ford's internal medicine clinic. Of these, 242 patients had spirometry performed and 210 patients met inclusion criteria. Among the 210 patients, 75% had obstruction on spirometry and 25% did not. Contrary to our initial hypothesis, there was no difference between those with and without obstruction on the rate of respiratory hospitalizations. Using a multivariate analysis examining risk factors associated with at least 2 respiratory hospitalizations, we found that reaching a threshold above 500 eosinophils per microliter, as well as FEV1% predicted, as risk factors that were associated with at least 2 respiratory hospitalizations, with p-values of p equals 0.001 and p equals 0.031. We then focused on the non-obstructive cohort and used a similar multivariate analysis looking for risk factors associated with a respiratory hospitalization, and once again found that reaching an eosinophil count above the same threshold was associated with respiratory hospitalization, with a p-value of 0.032. For a more detailed account of these results, including treatment risk factors not mentioned here, please refer to our manuscript within the International Journal of COPD. We can conclude that in a clinically diagnosed COPD population who had spirometry performed, the presence of airflow obstruction was not a risk factor for respiratory hospitalizations. The most significantly associated risk factor with respiratory hospitalizations, both in the study population as a whole and in the cohort without obstruction, was reaching an eosinophil count above the threshold of 500 eosinophils per microliter.